go through my differential diagnosis, there was one movement that really helped me understand more and more what's truly happening, and that was everyone. Welcome back to the podcast. Welcome all new listeners, those who have heard my content in the past. Welcome back. For those of you watching on YouTube, I'm in a new location with a different background. Just logistical challenges that I'm currently having, but nonetheless, here we go onto the podcast. Hi everyone. This is a near and dear topic, and it's actually very relevant in my life, and then a new story with my wife, who's currently battling this. But I wanted to share, and it's a great topic that we had recently at our latest team meeting at Sports Performance, and the progression of what's next with back pain. So this is kind of volume 2 sequel to last week's podcast with subacute low back pain. Before I move on, what is new, what is better in my life? Everything is great. Everything is in a certain direction, and I'm enjoying the road ahead with my family. My wife and I are doing great. We've been recapping all the craziness in our life, and what we're trying to do is make sure that both of us are taken care of, and we're, our relationship and everything that we do is stable and enjoying it. As chaos ensues, and you guys will realize this in life, that as you add more and more to your plate, life gets more challenging. And we were talking on the car. We had about an hour drive, and I said, in life, life is only I don't want to butcher this. Life is only as hard as it has hit you. And what I mean by that is, we thought life was hard with one kid, and then we had a second kid, and life was only that harder. And then as we add baby Jacob on, life is only as hard as it hits you. And so as we add different elements, we want to make sure that we stay very, very stable, and that we continue to focus on ourselves and our relationship. And so life only gets harder as much as you add more things onto your plate. And so as we renovate our second location, we're just adding more elements. And so somebody said recently, is it crazy, or is it hard? And I looked over at my wife, and if you guys know me, I will say, nah, it's not hard. Let's add more. And my poor wife is like, no more, please, no more. Because if you guys have followed me for a while, I enjoy the chaos. I enjoy the crazy, hectic life. I really do. I think it just challenges you to be more efficient, be better, and it finds loopholes in everything that you're doing. And I love it. I love every aspect of it. So that's what's better in my life, just finding grounding, and finding just balance in everything that I'm trying to do, and everything that we're adding in. So to me, it's like the coolest thing in the planet is to find more and more about myself and my family, and everything that we enjoy. So that's the personal side. All right, on to the topic. Subacute low back pain. Let me tell you why I'm doing this podcast. If you heard last week's podcast, you understand that I'm going through some back pain, and I love acute low back pain, and I love chronic low back pain. I love just managing back pain. I love managing people's challenges, and in the whole spectrum of the acute, subacute, chronic injury side. And about now, I'm on day 8. Day 8. I had 8 days ago. I had a back flare up from a deadlift. I was on a slight decline, and I just wasn't heavy. Anyways, I'll let you listen to last week's podcast to get caught up. But yes, I'm managing some subacute low back pain. Even me knowing all this data, and how to manage people's pain, I still had a little bit of a scare, and it was good. It was good for me. I always try and see the benefit out of anything that goes wrong in my life. I'm like, all right, good. What was so good about this that it's teaching me a lesson somehow? So now on to subacute. So last week I talked about acute low back pain and how to manage it, and how that's going to change your practice and the way you approach people. I think more importantly, like I if you know anything about me, I'll give you the the taping technique and the manipulation technique or the mobilization, whatever you want to call things, and the magic exercise that's going to do it. And I think that's going to like conquer 1 out of 1,000 people that you see, or 1 out of 10, or 1 out of 100. At some point, it'll help. But ultimately, I think the golden nuggets is the framework that you approach every single person that you're going to manage. And I think that's going to hit you with 9 out of 10 people that you're going to see versus like the one patient or client with the low back pain that like really was the perfect candidate for what I was going to talk about. And I think that's a challenge with a lot of CEU courses that you take. I think that they give you about 10% improvement in your practice, maybe 5%. And I think the approach that I'm trying to instill and help you guys with is the stuff that's going to hit 90%. The thing is going to most bang for your buck. How do you approach the people that you are about to see? It doesn't matter about the region, it's just about the person. So in subacute low back pain, why is this so relevant? Why is this so important? I think that if you work in orthopedics, I think that you're going to see a subset of patients or clients who fit this timeline. And I think subacute low back pain, it looks easy. And I think that it can be easy. And I think that you can also mess it up. And it's a very dangerous fine line, because I think most of us see chronic low back pain. We've seen it 1,000 times. It's probably 40 to 60% of all of the regions of the patients and clients that you see. So for you, it's like, I've seen this 1,000 times. What's so special about it? That's where any CEU course is going to help low back pain, because I think that you can throw certain techniques and 80% are going to get better in chronic low back pain. It depends on where in the spectrum they are, the psychosocial model. But I think low back pain, you can work your magic and you'll be fine. And acute low back pain, we talked about last week, that's rare, right? Like for most people in ortho setting, just from a timeline perspective, it's so rare that you get somebody 24, 48, 72 hours. That's urgent care or primary care type of stuff. Now, if you have a patient or client who happen to go to those places and they were lucky enough to be referred over to a physical therapist or told that a physical therapist can help them, I think now we're talking. This is we're more likely to see these individuals than the acute low back pain. And in my time in pro sports and in the current setting here at Sports Performance that we serve, we will see a lot more acute low back pain. But subacute, like all of us might see that. And that's why it's relevant. That's why I'm doing this podcast, because 1, I'm in the subacute phase. 2, my wife is just getting out of the acute phase into subacute for her low back pain. And I'll tell you her story right now. But I think that if you've seen the acute low back pain and you've heard my podcast on that, that'll help you tremendously. But on the subacute side, that's where I think we're all going to see it. And I wanted to share my progress and then my wife's story. Let me start with my wife's story. So the other night, we didn't even train. Like it was a rest day and we were going to relax, and we were about to get on the plane. And she goes, Chris, I'm going to go to sleep early and I'm going to get some stuff done. Sure, no problem. Goes to bed, wakes up, and she's like, I can't move. I can't get out of bed. And I was like, where do you need my help? And she says, literally, I can't. She had to crawl to get out of the bed, and I'll explain more. So she starts crawling, and our son Jacob was crying, and she said, hey, can you pick him up? No problem. And to get onto a chair to help him with feeding, she had to crawl and like combat crawl, because she couldn't flex or extend, just literally couldn't move her spine all that well. And it hurt tremendously just to extend, and almost like a Gower sign where you have to push your legs up. And I saw that and I said, what happened? I said, normally it's like mechanical things, squatting, deadlifting, those type of things will give her a little bit of twinges. But then this one was just purely lying down prone for an extended period of time. And we were about to get on a flight, and she's like, hey, what do I do? We have to go on this flight. And if you know my model and how I think a lot of people can conquer pain is literally pushing through it. And not everybody, a select population, a subset. And I told my wife, my philosophy, what do you want to do? And she's like, fine, I'll push through it. We have to, we have no choice. So everything went smooth, and she pushed through, and it was amazing to watch her, because I know only a snippet of what that feels like. But I've been in a position, I told you my story on when I was in England and about to go to Wimbledon with a pro tennis player, and I couldn't move my back. And I had to literally work that day to be able to support this person with a 35-pound table and be able to pick up their legs and, pick up their body parts and be able to like work on them mobilization wise and treat them. And I had to force myself, and that was the best thing possible. And my wife did it. She did incredible, and she got out of that. She went, we traveled, and everything was fine. We went back, and she did an incredible thing. And I think that she went from acute to subacute real fast. And that same day, I said, "How much better are you?" She said, 80%. I was like, "No, you did. No, not possible. How?" Because I was like, I'm at like 70. I said I was 70 at day 6. And I was like, how did you do that? And she goes, I just pushed through it. And that's amazing to me. And now she's doing great. And it's unbelievable to watch it. So now I'm in the subacute phase. I am day 8 after my injury. And I feel, gosh, I was feeling great. And then I had a small little twinge. I've kept moving. I was at 60, 70, and I went to 73%. And some of you ask, like, why do you always do percentages? Because I think pain is all relative. And whether you're 0, 2, 3, 4, and so are percentages. However, percentages give you relative improvement. And I think that when you ask people what their pain level is, sometimes they don't know how to describe that, like, well, it's not really a pain, it's an ache. And you're like, fine, just describe the ache. But when I say percent improvement, I think most people can understand that. So we go off of, everything is off of percent improvement. How much better, which percent? And they will say, like, I don't know, a little bit more. No, quantify it. Because if you don't quantify it, you're not going to know what the day-to-day or week-to-week progress is. So I'm about 73%, 73% better. And I feel good extending and flexing. Ooh, that didn't feel good. But I feel good overall. And so I'm on that subacute phase. So what do you do differently that you wouldn't have or couldn't have done in the acute phase? Well, this is where I start to push a little bit more. In the first 3 days, don't touch them, leave them alone, give them the guidelines, give them the bumpers, get them off to where they need to be. Just don't mess it up. And then I need to get them to, I described my scenario and my story to the team at our Tuesday meeting. And I did a whiteboard session. I said, here's kind of my progress. Here's what I'm doing. Outline, give me the questions. Where do I need to be? Where will I be? How much better? What's the timeline for me to heal? And we all work through it as a team. And I think it's very important, because even though as a provider, I know what my timeline is, it was great to hear the whole team understanding that, given my age, my activity level, my motivation, my psychosocial components, where would you put me on expected timelines? And we all agreed. So with the subacute phase, it's gonna take me about, on my progression, it's gonna take me about 14 days to get to at least 90% with ADLs, 90%. And somebody asked me, okay, what would you do next? Where would you start to train again? And I said, I would start at day 7 to get back in. However, the load is going to be so small. Actually, I don't know if I would do load at day 7. I honestly would just do body weight and movement, frequency, lower the intensity, lower the actual relative load. And I would just start going with a little bit of time-based, low intensity, longer duration, just move. And that's been great. I've been walking, I've just been moving in general. And then I've been doing some upper body, just bodybuilding stuff, because I can't flex or extend with load. So not a lot of active core work, just more static, and then stabilization based. But then I also can't do a lot of lower body stuff, because my extension and flexion, anytime that I get in a position of a lunge or those type of things, doesn't feel very good, even a box step up. So nonetheless, lower body has been minimal, upper body bodybuilding, and then now starting to add just long duration, low intensity movement, just to get everything moving, and then see where the limitations are. Are my limitations are into true flexion? Is it flexion-based problem? Into extension? Is it rotation? Lateral movement? What is it that's bothering me? I gave one clinical pearl that actually helped with the diagnostics. Because if you look at my paper on my profile on paper, you would say, Chris, from your podcast last week to this week, on paper, it sounds like lumbar spine. And now as I go through my differential diagnosis, there's one movement that really helped me understand more and more what's truly happening, and that was a lateral step. I went to grab something off of a counter and I did a lateral step to the left. My pain is on my right PSIS. Now, I lateral step to the left, and that was excruciating. Going to the right, no pain. Interestingly, standing on one leg, the right leg, no pain. Standing on the left leg, standing on the right leg caused pain, where standing on the left leg caused no pain. So as I go through the differential diagnosis, the subacute phase is really your time to explore more without having a lot of concern or fear that you're going to flare somebody up. So I understand that we all like to have a diagnosis or a diagnostics done early on to make sure that you know what you're treating. However, in 0 to 72 hours, you really have to be careful. You really have to be careful that you are not going to flare this person up. Once you get at that 72-hour mark and you're just looking at range and getting some mobilization, just getting them blood flow moving, great. This is the time now where you can start doing a little bit better diagnostics. You got to ask better questions to help you with that. Most people, as I went through my my symptom checklist, my symptoms are sharp with a little bit of ache, but sharp. Yes, it was traumatic because I was pulling off the ground, and my pain now is with flexion extension and lateral movement. Laying on my left side feels better, and my right side does not feel good when there is a lot of load on that. So as I go through this, yes, mine is now appearing more like sacroiliac pain. Whether you believe in movement there or not, it is definitely one-sided movement, and with flexion or disassociation actually hurts it. So why is the subacute phase so different? You now have opportunity to do more subacute testing, truly work on your differential diagnosis. So from a diagnostic standpoint, beautiful, gives you more opportunity. Now, from a treatment standpoint, like on the table treatment, what is so different? Most people are going to come in guarded. If you are working with an acute or subacute back pain or sacroiliac pain, what you're going to deal with, they're not going to love being prone. There's no way. Good luck. If you try it, you're trying to be Superman or Superwoman. Good luck to you. If you want to go supine, they won't be able to last long. You're going to have to pick a side, and you're not going to be able to flip them. It's like a burger. You don't flip them too many times. You're going to mess it up, and they're going to lose trust in you. So pick a side, stick with it, see what it feels good. Put a pillow between their legs, maybe something underneath their curvature of the lumbar spine so they can have a neutral spine laying down, and then constantly watching their eyes and there's three things you got to watch with every single time that you're treating somebody: their eyes, their hands, and their feet. You have to. If you're not obsessive about that, I know I'm talking to you, I'm looking at you, but I'm looking at your feet and I'm looking at your hands, just in case that you're trying to be tough and push through this. Some people don't know. They literally do not know that it's not okay to be uncomfortable during treatment, unless you're in the chronic stage and you're going to go deep tissue or whatever it is, and you know that, okay, there has to be a little bit of hurt to feel good. But in acute care, acute management, subacute management, they got to know there's no risk. I don't want to flare you up. Look them in the eye, explain exactly what it is, and I'm not going to think any differently if you just communicate your symptoms, because it makes my job easier, and your benefit, it's to your benefit to keep pushing and making sure that you're actually going through pain-free. So then I'll do is I'll just make sure that they're smiling, they're having a good time as much as possible, and just making sure that they're not actually flaring up. So I'll watch their hands, their feet, and their eyes. Big thing. Their eyebrows will start to move. They're like, oh, that's not a good sign. And sometimes they'll just like, oh, that's good. Yeah. And you see their hands are just white knuckling. Not good, guys. So yeah, pick a side, make sure that they actually feel good. and you're constantly watching that. And then tissue pressure wise, you're actually starting to push a little bit more just in case that they feel comfortable. You can start to loosen some things up. I think I will typically, if it's acute, subacute low back pain, I'm not going to go aggressive on the lumbar spine. Why flare that up? I'm just opening up the hips. I'm opening up T-spine, maybe a little bit of the upper traps. I'm going to hip flexors, quads, just allow the lumbar spine to get a little traction, open up so they can actually feel good. So tissue pressure wise, start to increase that. You can start to move them just a little bit more on the table. And then now you have a little bit more diagnostics. Corrective exercise wise, don't be Superman. Don't get them up and down. This is a thing, a challenge I see with a lot of clinicians. If you're used to dealing with chronic low back pain, you're used to supine table work, and then you do a comparable sign and you check them, you have them stand up, and then you have forward bend, and then you lay them back down, and then you flip them, and then you have to stand back up and retest. I mean, that sounds all really good in theory, but that's like a dentist working on your tooth and then stopping and then being like, sit up, let me see, double check, smile, let me see, I feel better. And the reality is it's better to conquer as much as you can, especially in this subacute and acute side. Get as much as you can, get them off the table, check once, and then you're done. Apply your taping techniques, apply whatever it is, and then corrective exercise, and you're gone. Don't do multiple comparable signs in a session. Don't do your symptom checklists in between your sessions. Don't go from prone or supine to stand and then go back to sideline and then stand just to make sure. That's great with chronic low back pain. You're not doing that with subacute. Stop it. Yes, they look like they're better. That's where the danger is. They actually look like they're doing so much better. And even though the subject is like, I feel 70% better, sounds good. The heroes are not the heroes in this side. What you want to do is you want to not be a hero and say like, oh, cool, now let's move you on fast. No, they're not at 4 to 6 weeks yet. They're still in that 2-week mark, 3-week mark. Stop it. All you're going to do is you're going to mess them up. You're going to go from hero zero real fast. And you don't need to be doing that. However, if you're a gung-ho, young clinician or experienced clinician is like, I've seen every low back pain, chronic low back pain possible. How is this different? Because the symptoms and the acuity is massive. It's like you having back pain. You don't want people to touch you. You're like, ah. And because if you can't empathize and you don't understand them, maybe you're frustrated, understand this is a painful time. I had a team member ask me, hey, Chris, do you want me to work on your back and do some soft tissue? I was like, no. That, to me, if you asked me, would like soft tissue or massage feel good with this stage of healing? For my body and how I respond, no. Because if I'm understanding that it is more sacroiliac in nature than true lumbar spine, and I had a shift when I did that deadlift, and I have my low back and my glutes just relax, my body naturally wants to feel like it could loosen up and just relax a little bit. And if it is my SI getting a little bit of spacing in there and I relax everything, I know I'm going to be unstable and I'm not going to like it. But that's just me. So that's why I need to know how to communicate my symptoms if I were to get work done. But that was great on the clinician side to say, hey, do you think that your body would respond to this? And that allows me an opportunity to say like, no, if I did, it'd be super light pressure. But I'm also very sensitive to the pressure and I can't handle a lot, ironically, as I deliver a lot of pressure to clients normally. So on the subacute side, just make sure you're not applying chronic low back pain principles yet. Okay, not yet. Get them out. I would say if somebody said, what's the biggest priority? How far out before you can start to treat them like that? I'd say minimum 4 weeks. All right. So going back to my session that I was talking about with the whiteboard session with the team on Tuesday and going through my history and what I think where I'm going to be at and where I tell people I think most clients will be at around the same stage with the similar style of injury. 0 to 48, 0 to 72 hours, treat them like an acute low back pain. Don't mess them up. Don't flare them up. Don't give them a lot for home. Keep them moving. Good. From 72 hours to 2 weeks, this is your time to get better at subjective diagnostics and make sure you're on the right path with what you're treating. But don't flare them up. Don't flip them too many times. Start to gently increase pressure, not over the site of injury, all aspects to help them relax. Continue to give them exercise progressions or bumpers and modifications to what they can do in their ADLs, but then also in their general fitness. If they want to do long duration, low intensity, great. Get them to the 2-week mark. Perfect. Once I get to 14 days, 2 weeks marks to 4 weeks, now we're talking. Now they can get back in a little bit of exercise. If their choice or mode of exercise is high intensity, they're not there yet. You got to get movement with light bodybuilding, low tempo, real nice and easy. Have them figure it out. Maybe go on the bike, start some rowing. I wouldn't start with any intensity yet. That is the last factor. So what I would do is work on the time and the type of exercise, just like your frequency, your FIT principle, FITT. I'll go the time and the type, increase the frequency, and then lastly, increase the intensity. You will destroy yourself or that patient or client if you mix those up. That's where the challenge becomes in. So if you ask me, which one would you do? I don't know. You choose. That's what the type of exercise, whatever floats your boat, they have resources for. The time, the duration that in which they do it, then the frequency, start to pick that up, and the intensity. Intensity won't increase at least until week 4 or 6. So in the 2 to 4 week mark, now we're starting to look at, let's increase that duration and increase the frequency. From 72 hours to 2 weeks, you just had the type, figure out something they can do with longer duration, low intensity, low frequency, to start walking, to start moving. Great. You've hit the 2 week mark, nice and easy. Now we're starting to increase the frequency, maybe change up the type and the time. Keep that constant, increase it, do whatever you want, but do not touch intensity minimum until 4 weeks. So as we go through subacute phases, just know your FIT principle is still very, very high on priority. Don't overdo it. In the acute phase, leave them alone, don't mess it up. Subacute, this is where they're dangerous. This is where your patients and clients are dangerous, because they start to feel better, and that's when you start to push the button. Pull back the throttle, easy, relax. Give them a 2 week mark, 2 week mark to 4 week mark, with getting up to that 90% mark. If they get 90% with ADLs, perfect. We're starting to work out a little bit more. Pick something low intensity, low duration or high duration, and that you enjoy. You have resources to. Well, can I go for a walk? Yes, absolutely. Just keep the blood moving. Can I on the bike? Yes. Be careful with the flexion and just pedal around on it. Can I do the stepper? Be careful. Just putting pressure through one leg. Treadmill, great. Change the incline. Make sure it's not too far an extension or flexion. That might be the case. So I'd go flat and then increase that. So 2 to 4 week mark, there's your guidelines. And at that point, what you've done is you've successfully got them into the next phase. What would happen if they didn't see you in the subacute phase? You know what happened? They would probably go and mess it up again. Why? Because sometimes they need, as I lead and coach my team, as I mentor other PTs, as I start to help my kids develop, the thing I realize more and more is that we all need feedback and we all need that support. Even if we've done it 1,000 times, it's nice to know, like, is that safe? Like, do you think I'm crazy? Should I go this direction? No, it's perfect. Stay the course. And I'll have PTs come to me, hey, Chris, this is where I'm thinking. I've got a patient client with, low back pain. They've been doing this, hip pain with this. I've tried this, this, and this. I haven't gone here. Their percentages are here. They have a competition coming up. I'd like to get them here by week 7, 8, 9. This is what I'm thinking. What do you think? I'm like, oh, beautiful. Like, you have everything in place. Just be ready. If it doesn't work out, what are you going to do next? That's the only element I would do. So sometimes we just need that. We need that support. And if you're a new grad, you better believe you need that support because you're new to this world. And I don't care how good your CIs were, you haven't seen everything yet. I haven't seen everything yet. I still ask, mentors for help. Hey, do you think I should have gone that way? Why didn't I? And then ultimately you become one of your best mentors in just constant reflection off of it. And you start to hear patterns in the feedback that people give you. But sometimes you just need that, like, it's good to go. right direction. And sometimes the subacute phase is just that for that person. It's the, hey, we're on the right track. You need to get to week 4. And even if you don't see them for 2 weeks, that's fine. That alone, and telling them you have to, do this, avoid this. I'll see you in 2 weeks, and you have to see me in 2 weeks. Why? Because legitimate, they will need support at every, timeline point. And why is that important? Because you and I, the people listening to this, still question how fast they should push people. It's the nature of, the perfectionists, the PTs, the OCD, the ones who want to be the best. You naturally want to do what's right. Good for you. And because of that, it's very scary to make those decisions because you want the best for your people, the best for your patients and clients. And you need to be assured that there's low risks. And that's all you're trying to do. I'll be honest with you. I've progressed people my entire career. And every time I have an ACL, I have a hip repair, I have a very important, person in front of me, and they have a timeline that they want to get to. Every stage, I'm like, oh, if I push a little, like, is it worth that risk? It's just risk assessment. Every single time, you're like, what's the risk if I throw in external rotation at 90 now? That's all you're asking. It's always assessing risk. It's not if they're going to get hurt, it's the risk that they're going to get hurt. So every single step is just percentages dropping of risk, right? And so if you look at messing somebody up from 0 to 72 hours, there's a lot of risk. So why risk it? Don't risk it. 72 hours to 2 weeks, still in a risky spot. Don't risk it. Allow them to choose a mode with a longer duration, low frequency. Just get them moving. So you can see when somebody hurts themselves on their low back, high risk. Don't mess it up. Subacute, lower risk. Get them to 4 to 6. Now we're like, oh, I've seen this before. This is now in my wheelhouse of people that I've seen. Now you can start to push the throttle. So now you have risk going down and you have actual tolerance going up. So you're just always balancing risk tolerance. It's early on, they have a lot of risk. Drop it down. Don't touch them. Decrease the risk. As they start to get to that 6-week mark, you see this like inverse relationship. Boom. Now you can start to push them. Now you can say, well, Chris, why can't you just wait till 6 weeks to see them? Take every single model in the healthcare model. Because they would be worse. Why is that? Because it's like molding something perfect by saying, if I saw them from day one, I can guide them along the way so they're stronger, more resilient, know the expectation, and independent prior to 6 weeks. Worst case scenario is they saw nobody for 0 to 6 weeks. Why? Because they didn't know what to do. They probably were now in fear avoidance. They probably gained weight. They're probably having trauma. They probably took meds. That's why you don't see somebody and wait till 6 weeks. We're the best people poised to see that person in between. Why? Let's not take meds. If that's the thing, cool. Take meds to get you early on, but wean you off, because if not, movement is medicine on this. Yes, you can use meds early. Perfect. Get them off of that. You decrease the risk of them having the psychological trauma. Why? Because they need somebody there for support along the whole way. Gained weight. You can help reduce that by increasing them or getting them move immediately after 72 hours. Just keep them like walking, doing stuff. Even if they say, can I walk 5 days a week? Yes, you can do that. That's all they needed. Do you understand? So I think that if you don't see people 0 to 6 weeks, you're doing more harm. I think if you see them 0 to 72 hours and you don't do anything, you don't know what to do, that's a skills-based problem. That's just because you've never seen it before. So I think the big takeaway you have to understand is at every stage that you see somebody in a subacute phase, I know this podcast is about subacute pain. However, at every stage that you see somebody, ultimately, you should be doing a risk assessment. That's ultimately what it is this risk worth the outcome that I can get? So if you're going to truly work on a grade 5 mobilization on somebody day 2 or day 3 from a lumbar spine, acute phase or subacute phase 10 days out, is this really worth it? Do you need to do that? Benefit to risk ratio. Is it that much benefit that you're going to get? And you better be ready to see what comes afterwards. And if you see it 1,000 times, good for you. If you've never seen it, don't do it. Don't be the hero to zero. I would never do that. And I've seen a lot of acute low back pain management and my own. And I'm managing this right now. And I told the team, I wanted to share with them that, and I don't want you to take this out of context. Don't splice this audio file or this video file or put me on blast on Twitter or Instagram. What I'm saying is, if you've been hurt as a PT, good for you. You know what that feels like. And every stage that whatever your age is, 22, 27, 88, 25, I don't care. You getting hurt, you got to see some benefit out of that, right? Like, why did I have to fall on my shoulder? Good, because it reminds you of the people you serve. You're welcome. Somebody's telling you, like, you're welcome. And all that does is like, oh man, my patients and clients, they go through this every day. And because you're in a rhythm and you see, I don't know, 30 people a day, or you treat 10 people or 15 people a day, you get in this routine. And you're like, here we go, another low back, another shoulder. No. You remember what that felt like? You not being able to sleep, how miserable that was, how mentally crazy you were about to be, can't wash your hair. It's not even that. It's just inability, like the lack of independence that you lost. You felt like you were dependent. I asked my wife the other day, hey, can you put on my socks for me? And she knows how much I love when she helps me with my socks. Only because if you've heard my first podcast and like 3 podcasts ago about just my story, my grandma raised me, and I was born and raised by her. And I born and raised in San Isidro, and my grandma really truly raised me, and she would put on my socks every day. And I was so spoiled. I was her only grandchild, so she'd put on my socks every morning. And my wife hates it because she's like, nope, don't expect that from me. And so my back was hurting so bad. I said, hey, can you put on my socks with this smile? If you're on YouTube, I am so smiling so big. And she looked at me, she's like, don't count on this. Don't you dare get used to this. And so for me, I think it's a good thing. It's a good reminder, right? Like nobody wants to be hurt, right? But I got to see the benefit in it. Like, how does this come and help me in my personal life again? How is this helping me? And that's one of my biggest passions. My wife will tell you that. We were talking on the drive back here before doing this podcast, and she's mentioned this before. She said, you just like don't stop like trying to figure out why things happen. And I'm obsessive about it because I think that it helps me build my character and then helps build other people's character, in that there's good out of most things, right? Like there's good out of it. We got to figure it out. And so the next time you get hurt, you hurt your shoulder, you hurt your low back, and you tell me about it, don't be offended. But my natural instinct sometimes is just to be like, good for you. And it's not because I'm happy about that. It's about, great, what's the opportunity from this, and how does it change your viewpoint to the people you serve, or maybe your spouse or your kids or your family or somebody who just got hurt. Like, it gives you good perspective. And so I'm saying my back is hurting and it's feeling better. However, it's not there. And so when my clients come to me, I'm like, man, I know where you're at. Day 8, not fun. However, I know what the light looks like. There's light at the end of that tunnel, and you can describe that better. So when they're in the subacute phase, I know they've got great potential. But if they don't hit day 28 at the 4-week mark, if they don't hit that with the same progress, I know they're going to get worse, and mentally they're going to be challenged, and they're going to lose motivation to go back to where they were. Maybe they're on a high of exercising or going to the gym or running. They'll lose that. They'll get off track. And so sometimes we're just the guide to help them get to 6 weeks. In the subacute phase, this is where they're going to need you the most. Earlier on, just told them what to do. Don't touch it. This phase is where they want to start to try more. Don't let them do too much. Don't do it. Do them a favor. Just transition them into the 4-week mark, start to let them exercise a little bit. And then when you get to that 6-week mark, that's when you can throw in the intensity. Just a general guideline, I would say it. Somebody asked at the whiteboard session, they said, Chris, when would you start to increase intensity? I said, I'll start to get exercise from weeks 2 to 4. I'll start to maybe go 75% from week 4 to 6, and that 6-week mark, I'm all in. But I got to hit 90% before I'm all in, like 90% with general fitness, ADLs. And I'll tell you a fun story. One of the ACLs that I managed earlier on in rugby, and this person needed to get back fast. I mean, the fastest ACL to full trauma was like 4 months, and gosh, that's a fast timeline. And we had some stuff coming up, and I had no choice but to help transition this player, and they were in. They wanted it, and it was so scary rehabbing this. I mean, we were doing daily treatments twice a day, Monday through Sunday. And I remember it was a cool experience. And at every phase, I was asking, how much risk is there? And then I remember at week 12, so 3 months, I had to start doing like a little bit of like trauma and like work on as if they were going to get like pushed from shoulders and working on dynamic stability. And this person, I ended up playing at full throttle world tour, probably 5-6 months. And I remember asking him, I was like, hey, how? Because I'm obsessive about percentages, and I wanted to be at 90% before going in, and all their testing tested out, objective testing, and criterion based went through as well. So I asked him, what percent were you? I said, you told me 90% going into training again, and I said, and you were giving me percentages going in, 95, blah, blah, blah. I was like, when did you hit the 100% mark? Was it like 8 months, 9 months? He goes, no, it's when I took that first hit on the field. He took a hit, and they came from the side, and they hit him on the injured knee, and he got up, and he was like, all right. And that moment is when I realized you can only take somebody so far before they need to get hit and get hurt. They need to understand what that feels like. So if you ask me, going back to my back pain, how do I know I'm at a subacute and I can start adding intensity? I know my timeline, but at some point you got to let me fly. I'm going to go back there, I'm going to train, and I'm going to deadlift again. And that's when I'm going to know I'm 100%. Not obviously at 400 pounds, but at some point I'm going to hit a training point where I'm like, this is it. I feel good. I got to try it. And they go to lift, and I'm like, oh, not bad. I guess I'm 100. And so you have to let your patients and clients fly, but not too soon. At every stage in the subacute phase, you got to ask, is this worth the risk benefit? So there you have it. That is my take on a subacute low back pain. And it can be applied to, SIJ pain, whatever you want to do. But I think ultimately this is a cool opportunity for you to see more patients and clients. And you do this and you follow this sequence and you get them better. There is nobody more important in this world than you in their life, in their viewpoint during that phase, because nobody wants to be in this pain. It's excruciating and nobody loves it. However, everybody loves the feeling, and they will remember the person who helped them get out of that. So believe it or not, you get a lot behind that. The urgent care, they'll find you, you start partnering with them, calling them, hey, I got some, hip tips I can help with any low back pain, local hospitals, surgeons, primary cares. You start to build a name for yourself and the people that you serve. And so get one person better and you will get many. That's just what it is. Don't be hero to zero. Don't use your chronic low back pain principles to subacute. Still not there yet. Okay. So I hope this helps. More than anything else, as I mentioned, I want to give you information that hits 90% of the people you see, not just the 10% one-hit wonders that you'll maybe get better. I'm not a CEU course in that fashion, and that's not my passion. So I hope that helps. And if or when these things help you along the way, shoot me an email, drchris@drchrisgarcia.com. Let me know, because I love this stuff. I'll eat it up. I will personally respond. If you're like, Chris, that one podcast helped me out with this person, perfect. Tell me why. and then we'll build off of that, and I will share that, and that helps me tremendously. So uh, hope you loved it. And you guys are doing great. Thanks for putting up with me and my current YouTube Audible that I had here and my new screen that I had to play with. If you guys are on audio, I hope you guys are doing well. I want to say thank you to all you listeners. Man, I can't believe the surge that is happening through this podcast and the feedback that is happening. Recently, we launched the announcement that we're having a second location with sports performance, and the amount of feedback that we've gotten from a lot of PTs saying, "Hey, Chris, where can I help? Congrats on the location." And even yesterday, there was 3 people who reached out and said, "I want to be part of that. I listen to your podcast, and I just love everything about you doing." And I gotta say, I'm so thankful, and I'm gonna crush it. I'm gonna continue doing this stuff because of you guys, and I'm loving that it's helping you, because I promise this is 10 years of no, 13 years of practicing. And this is everything that I've learned and consolidated with some of the best mentors on the planet. And they pushed me and to a point where, man, I've been in tough places professionally, and they really pushed me to a good position here. And as I build and gather a bigger team for sports performance, I learned that leadership and the way that you approach people is all about the relationship that you have. And I love the people who are part of that team. And I want to tell you that everything that I'm telling you guys is what I'm telling my team. Honestly, I'm super genuine about it. I think that you got to learn from mistakes. You got to get hurt. You got to know what that feels like. You're not going to hit 100% until you actually get hurt again, or you test it. And this is the same principles to life. And you people on the podcast, thank you so much. The amount of listens there or downloads that are coming off of this podcast are just unbelievably growing. And so thank you for sharing. That means you guys are sharing it with your world and your friends and colleagues, and that I appreciate that tremendously. I just want to say from the bottom of my heart, thank you guys. Okay, I'll continue. My promise to you is I'm going to continue crushing it, giving you more stuff, and make sure that you guys are successful, because that's ultimately the purpose of the podcast. So, all right, guys, I hope life is amazing. I will catch you guys on the next episode. I have no idea what it is. I'll give you updates as we go along. It's everything that's happening in my life and everything that I'm seeing and hearing. So, all right, until then, I'll see you guys on the next episode. Take care.